Awesome. And I'll still try to get this recording up sooner rather than later. But today we're going to finish up Neurophys. I want to try to do a little bit of Neuropatho just to kind of give us a head start for tomorrow's stuff. Tomorrow's Neuropatho stuff, it's not bad. It's just a bunch of like little random topics that aren't very connected to one another. So yeah, cool. And then tomorrow when we meet, we'll have an exam debrief. We'll go through the stats, so averages, standard deviation, highest scores, and then I don't single anybody out, don't worry. The 5 most missed questions. Okay, I will have your exams unlocked tonight. I want to say 6:37-ish after the last class takes theirs and everything is processed. So yeah, you guys should know sooner rather than later. Okay. Cute. All right, so a little bit of anatomy here. The meninges. The meninges, this is the protective membrane around the brain. It's kind of weird, it's also the spinal cord. So your meninges is not just in your skull, it actually extends down into your spinal cord, your spinal column. 3 layers. You have the dura mater, which translates to hard mother. You have the arachnoid layer. Arachnoid because it looks like a series of spider webs. This is basically like a river of CSF, that's cerebral spinal fluid. So a little bit of recap. Anybody remember who makes the cerebral spinal fluid? What cell? It's at the choroid plexus. Starts with an E. Epidermal, yeah. Epidermal? I don't think I spelled that correctly. I think there's a Y in there. Cells. And then pia mater, this means soft mother. So of these 3 layers, which one would be the most external? Dura mater. If you're getting into a fight, which mom are you bringing with you? That's the way I remember it. Okay. So dura is the most external, pia is the most internal. All right. So talking about cerebral spinal fluid here. You don't need to know this number here. You actually have a very, very tiny amount of cerebral spinal fluid. It's not much. Anybody know what 150 milliliters looks like? It's basically give or take a shot. That's it. It's not much. And it's produced by the choroid plexus. Here we go. Epidermal cells. That's what I was referring to earlier. Okay. All right, so brain. We're going to be talking about some generalities here. You need to know in general what the lobes do. I'm not turning this into like a psychology class or anything, but just generalities, okay? So we'll start with the left side. Anybody know what the left side of the brain is responsible for? Yeah, the way I kind of remember the left side, it's going to be all about logic and language. Logic and language. For the right side, that's your creativity, if you will. Okay. And kind of like spatial awareness, but you don't need to worry about that. So fun fact, who has in general a denser left side? What I mean by denser, more neurons. So whose left side is more active, males or females? Females. This is my reasoning for why I can never win an argument against my wife. Okay, she's got language and logic on her side, but I can finger paint really well. Okay. So in terms of lobes, different lobes you need to worry about. First up is the frontal lobe. So just recapping, anybody remember what the frontal lobe does right up here? Kind of foresight, forethought. Anyone? Not motor quite. Okay, yeah, I call it basically, this is the lobe that gives you your humanity. This allows you to process emotions, to understand that murder is wrong, that kind of stuff. So I'm going to say higher cognitive functions. Okay, next up is, let's say, parietal lobe. So it's going to be kind of the sides here. Yeah, it's going to be sensory integration. Okay, so take for example, when we're doing exploratory brain surgery, we're going to cut off the scalp and then the skull, leave the brain exposed. We take an electrode and start poking and shocking different parts of the parietal to map what it does. So patients can report things like, my mouth tastes like peanut butter, or they can also lose the ability to talk, or I can feel my left pinky toe tingling. Okay, so it's just kind of interacting with all of the senses, putting together that sensory information. Temporal. The temporal lobe, the way I kind of remember it, so here's your temples, the closest organ next to that. So temporal is going to be roughly for hearing. And then let's go cerebellar. Cerebellum, sorry. Cerebellum here, this is going to be for movement and coordination. I cannot run out of room, sorry. Brainstem. Anybody familiar with what the brainstem does? I'm going to combine both of your answers. Vital reflexes. Vital reflexes. So again, have a general understanding. This is going to extend into, oh man, I forgot another one. Sorry. Occipital lobe. Sorry. Last one, I promise. The occipital lobe. Yeah. Vision. So the reason why I say that, like, have a general understanding of this here is between health assessment and patho. Patient slips on ice, slams their head into the sidewalk. We know there's damage to the occipital lobe. What symptoms should the nurse expect upon assessment? Vision issues. Okay, take for example, patient has to have their temporal lobe removed. What symptom would a nurse expect? Loss of hearing, something like that. So just heads up, no general lobes. If there's a damage, kind of what to expect there. Okay. All right. So this here shows the corpus callosum. That's kind of like the bridge between the left and the right. So let me say the left brain controls which side of the body? Right side. Right side. Right side of body. Okay, so same thing. Patient suffers a stroke, suffers severe damage to their left occipital lobe. What symptom would the nurse expect? Left occipital lobe. Right side blindness, something like that. Okay. Right side of the brain, that's going to control left side of the body. Okay. All right. Couple of structures here. You don't need to know this entire thing. But first up, we're going to talk about the substantia nigra. This is going to be responsible for fine motor control. So you writing on your piece of paper right now, you're using your substantia nigra. The reason why we bring that up is we're going to talk about certain pathologies. Pathology specifically affects substantia nigra. You can expect kind of more varied movements. Other one, hypothalamus. We kind of talked about it with exam 1. What's important about the hypothalamus? Temperature control, yeah. Okay. So those are the only two that you're going to need to worry about for me. All right, so here's a nice little overview. The one I need you to focus on the most is the brain stem. These are your vital reflexes, things like blood pressure, breathing, etc. So, which is the last part of your brain that you want to damage? Probably the brain stem. Let's say if it does become damaged, if you do damage your brain stem, what would this patient look like in the hospital? So they have no ability to regulate blood pressure. They have no ability to have their heart beat. They're probably hooked up to life support. Okay. All right. Everybody's favorite. The cranial nerves. Sorry. Yeah, you guys kind of need to know this. I got you. So let me kind of explain where we're going with this. So yes, you do need to know the cranial nerves. Heads up, they are usually written with Roman numerals. Okay, I write Arabic just because it's a little bit easier to kind of write it and see it. Just in the medical field, you will see it via Roman numerals. Okay. Now, when it comes to cranial nerves, I am not going to go nearly as in depth as your anatomy class. Okay. So a couple of mnemonics to help you guys out. I'm going to go with the default one here for the name of the nerves. It is O, 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 to touch and feel very good velvet. Ah, heavens. Now, that is the one I learned. That is the one I am teaching you. But that is not the one I remember. There are several different mnemonics out there. If you are into raunchy humor, you can look it up. If you are into Harry Potter, there's like 3 different Harry Potter ones. I am not going to say the raunchy one, just because I like having a job. Whatever helps, this is the default. Okay. Now, for the functions, some say marry money, but my brother says big. Now think of a body part that starts with B. Brains matter more. Okay, these are, I actually kind of like that one. That's the only one I know of in terms of a mnemonic for the functions. Okay, and we'll run through it. Okay, so again, everything is usually in Roman numerals there, just as a heads up. Here are your names. The next slides are just for me to write on. If you want, you can just write on this slide, whatever works for you. I just need to have a little bit more space. So O, 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 to touch and feel very good velvet. Ah, heavens. So I'm just filling it in here. Factory. Clear. Try Gemini. abducens, facial, vestibulocochlear, glossopharyngeal, vagus, accessory, hypoglossal. Okay, so I'm just writing in the names there. And then for the functions, some say marry money, but my brother says big vajungas matter more. It's not very often you get to use vajungas in lecture. Okay, so need to know the names and then relative functions. So what do you think S stands for as a function? Sensory, because olfactory is primarily sensory, and olfactory, what sense is it giving you? Smell. Okay, optic. Oh, it's sensory as well. It'll give you sight. That's the level you need to worry about for me. Not getting too crazy with it, okay? So again, take, for example, patient gets COVID, reports damage to cranial nerve number 1. What symptom might the patient experience? Loss of smell. I could also flip it. Patient reports being in a car accident. Now they have trouble seeing. Which cranial nerve might be impaired? Optic nerve or cranial nerve number 2. Okay. Oculomotor. So it's still motor, so it's for movement. Eye movement. You do not need to know which direction. Just eye movement. Good enough. I don't think Lindsay gets into it either with health assessment. Trochlear. Motor. Eye movement. Trigeminal. So B. What would B stand for? Both. Sensory. Okay. Sensory is going to be for facial sensory. So when you feel the cold air, the cold wind hit your face, you're feeling that with the trigeminal. Okay. The way you guys assess this in nursing, you take a conduit, you draw it across the patient's face. If they can feel it, cranial nerve 5 is intact. Okay. In terms of motor, this is for mastication or chewing. Okay. What would you be worried about if a patient's cranial what would you be worried about if a patient's cranial nerve 5 was impaired? What are they at risk for? Loss of sensation and also at risk for choking because they can't chew. Okay. Abducens motor is just for eye movements. So yeah, you have 3 cranial nerves responsible for eye movement. Now, if you're being particularly studious or you're trying to like kind of read my mind, that sets it up for like a nice select all question, doesn't it? That's the way you guys should kind of be thinking about this material there. Just because it's not only my class, but you guys have to learn these for health assessment. They do the same thing, right? But if you jump on it now, less for you to worry about in health assessment. Facial. So this is, be careful. This is a common thing that students always mix up. The facial nerve does not sense your face. Which nerve senses your face? Trigeminal. For sensory, it's involved with taste. The motor is how it gets its name. That's the facial expressions. One of the common signs of a stroke is facial asymmetry. Which cranial nerve is most likely impaired? Ta-da. Okay. Vestibulocochlear, sensory. This is for hearing and balance. So when somebody drinks so much and they start doing that roadside sobriety test and they're stumbling over themselves, alcohol, CNS depressant, suppresses cranial nerve number 8. Like you kind of have to yell at, the drunkie a little bit. All right, glossopharyngeal, sensory. Okay, so your gloss, I kind of think of glossal, like your tongue, like glottitis, if you will. So we know that it's involved with something involved with the tongue. So sensory wise, this is going to be taste, motor. This is going to be tongue movement. So this can be, I'm just keeping it general, tongue movement. This can be for speech or swallowing, but just keeping it general tongue movement. Okay. The vagus nerve, sensory, motor. Now, what kind of interesting about the vagus nerve is it deals with the abdominal, actually, I would say your trunk organs for both sensory and motor. Okay. So your vagus nerve gives you feedback about what's in your abdominal section in your core. So let's talk about sensory first. A stomach ache. If your stomach is hurting, your vagus nerve is transmitting that signal. Okay, do you ever feel like a twinge in your heart? Vagus nerve. Now, in terms of movement, can you move your heart from one side to the other? The type of movement that I'm talking about here is like a heartbeat or your stomach's peristalsis. Okay, so it just helps them contract in place, but don't think of it like as full-on movement of your lung or something like that. Okay. So open heart surgery, we have to stop the heart. Which nerve do we need to knock out? Yeah. The accessory motor. Okay, the way I remember this one, where do you hang your accessories? Talking about purses. Yeah, your shoulders, yeah. Shoulder muscles. So tying this into health assessment, how would you assess a patient's cranial nerve 11? Yeah, you shrug. Exactly. Hypoglossal, glossal, there it is again. Motor, tongue movements. Okay. So that's what you need to worry about with the cranial nerves. Not nearly as bad as anatomy. Okay. Name, function. I would say get used to writing out 1 through 12. Write out the acronym or both acronyms, and that should help you kind of solve your way through. Okay. All right, so this slide here, please do not misunderstand this slide here. A lot of students do. Optic nerve, sensory or motor? Sensory. Oculomotor, sensory or motor? It's in the name. Motor. Right. Trochlear, motor. Abducens, motor. So how many cranial nerves are associated with the eye? 4. 4 are associated with the eye. 3 of them are motor or eye movement. 1 of them is sensory. So all I'm saying is be careful here. A lot of students misread this, like, oh, there's 4 nerves for eye movement. Incorrect. There's only 3 for eye movement, 1 for sensory. Okay. All right, so your spinal cord, all I'm emphasizing here, your dura mater, your arachnoid, your pia mater, all of that extends into the spinal cord as well. Okay. All right, so now we're going to talk about a simple reflex arc. Let's see, so step 1. Stimulus detected by your nociceptor. Nociceptor is a specialized nerve ending for pain. Okay. That's going to send a signal towards the spinal cord or towards the central nervous system. What kind of signal are we sending to the central nervous system? Sensory or afferent or, I was gonna say ascending. Okay, so just recapping: sensory, afferent / ascending signal to the central nervous system. So what does that tell you about this nerve in blue? What kind of nerve is that? Sensory nerve, motor nerve, sensory, via sensory nerve. Okay. Now, we get to central nervous system, we get to this guy right here. This is your interneuron. So step 3, we get to the interneuron. At this point, your interneuron has a decision to make. So interneuron decides, I got this, or I need help. Okay. Your interneuron is going to have to decide with this signal. Do I have this? Can I appropriately handle this? Or do I need to send this to my brain? Okay. So kind of think of it this way, like for a simple kind of signal, simple reflex, what do you want your interneuron to answer? I got this. Sorry to check. Complicated stuff, which we'll talk about, that's going to go up to the brain. So in a simple reflex arc, it's going to answer, I got this. Okay. The simple reflex arc, that's its answer. So now we're going to send a signal out of the central nervous system. What kind of signal are we sending out? Motor, efferent, or descending. Signal. Signal away from the central nervous system via, I'm going to say motor nerve. So then we finally get to the muscle. That causes the muscle to contract in this case here. Cool. What is an example of a simple reflex arc that you as nurses will test? Hot or cold. That's actually going to be a complex reflex. Yeah, you're going to run around, you're going to smack patients in the knee, for lack of better terms. You're going to have a rubber mallet, you're going to smack somebody in the patellar tendon. What should happen? The leg should kick out, right? Question then, application wise. Will a patient feel pain?
Sure.
They shouldn't. Why?
So you're just activating, but there's some pain in your body doesn't actually.
Mhm. In order for us to feel pain, which organ has to be involved? The brain. In order for us to feel pain, the brain should be involved. In a simple reflex arc, does the signal go up to the brain? It says, I got this. So does that mean they need to be conscious for you to test this? You can actually try this while people are sleeping. No kidding, you will see legs jerk. They would never know, they didn't feel it. Yeah, I mean, you guys got loved ones, family members, Thanksgiving's coming up. Good reason to interact with the mother-in-law, you know what I mean? So what's kind of interesting is people who are not conscious, you can test their reflexes. Another one is pupillary constriction. Okay. In theory, again, because this doesn't go up to the brain, they're not aware of it. They're not conscious of it. Okay. So no. Okay, unless they're in stage 4. If they're in stage 4 of sleep, their body actually paralyzes themselves, so you actually won't see this reflex. It's kind of crazy. So reflex arc, just those kind of parts which we talked about. Okay. Why? I mean, who came up with the bright idea of smacking people in the knee, right? Anybody ever pull a tendon, stretch a tendon, tear a tendon? How much did it suck? Your body does not like to have its tendons stretched. So when you apply a hammer and you stretch out that tendon, that signal goes towards the central nervous system to that interneuron. Interneuron says, I got this, signal comes out. You contract this muscle to shorten the patellar tendon to protect it. Okay. What I'm trying to talk about here, your reflexes are different from your reaction time. Two different things here. You smack somebody in the knee, the leg kicks, it doesn't mean that they're reacting very quickly. Okay. One thing I do want to highlight here, this structure right here, this right here is called the dorsal horn. While this one is called the ventral horn. Okay, you might hear it call it a root, so like ventral root, dorsal root. I call them horns, that's the way I was taught. Okay. So taking a look at this diagram, the dorsal horn carries what kind of signals? Sensory. Therefore, the ventral horn must carry motor. So the idea is in through the back. In through the back, out the front. Okay. Dorsal, think of like a dorsal fin on a shark. It's in the back. All right, little bit of anatomy review, nothing crazy. Cervical vertebrae, how many you got? 7. Thoracic? 12. Lumbar? 5. Don't need to worry about the sacrum or the coccyx. The way you can kind of remember that, it's going to be meal times for like a normal person ish. 7, 12, and 5. Okay. 7, 12, 5. Okay. For nerves, 8, 12, and 5. This one, meal times on the weekend, where you, in theory, got 1 extra hour to sleep in. In theory. All right. So here, just highlighting again, your dorsal carries signals, again, sensory signals in through the back, goes to the interneuron, and then out the ventral root. Okay. Okay. So a couple of terms here. Dermatomes. Dermatomes. Derma refers to what? Like a dermatologist. Skin. So dermatome translates to skin areas. Skin areas. I.e., where one area of skin is innervated by one nerve. So dermatomes is one area of skin where there's only one nerve, as opposed to myotomes. Myo means muscles. So myotomes, this is a muscle. I'm not even going to try to translate it. It's going to be weird. So I'm going to say where it's one muscle innervated by one nerve. So US nurses will be assessing dermatomes and myotomes. Why? I'll give you an example and then we'll come back to it. Okay. So therefore, are myotomes efferent or afferent? Myotomes. Efferent because they're motor. Dermatomes, therefore, must be afferent. Okay, so this is a chart you're going to see in a lot of emergency rooms. You don't need to memorize this chart. I'm going to say you do not need to memorize this chart. Okay. What I want you to kind of see again is the overall picture. So let's zoom in here. This is mapping the various dermatomes. Okay. If you take a cotton swab and you swab this part of the head, and patient reports, I don't feel anything. That area is innervated by cranial nerve, not cranial nerve, cervical nerve 2. So if the patient can't feel that, what does that tell you about that spinal nerve? It's damaged. You start like different patient. Let's say a different patient here. You start poking around with your cotton swab. Okay, I can feel that, I can feel that, I can feel that, I can feel that, all the way down to I can't feel that. What does that tell you? So why are dermatomes useful? Yeah. The idea here is we're assessing your spinal nerves. This is going to be a quick way to assess your spinal nerves. If I poke a certain area, I know that's innervated by a certain nerve, right? So this is mapping. So why is this important? This allows us to map spinal cord injuries. Okay, if somebody says, I can't feel my legs, we need to see how far up that is. So this is a non-invasive way to literally map this, and it can be done pretty quickly. Okay. So again, don't need to memorize the chart, just overall picture. Why are dermatomes and myotomes important? Okay. So dermatomes is what you're feeling. Myotomes just applies to what they can do in terms of contractions. Okay. So a little bit of an exam question. I know you guys did that before. Sorry. 20-year-old patients brought into the ER, motorcycle accident with possible spinal cord injuries. Which two portions of the spine should the nurse assess first? We say cervical. I agree with cervical. But I disagree with thoracic. I argue cervical and lumbar. Why? So I start poking at their toes. So again, motorcycle accident, right? I poke their toes and they say they can feel that. What does that instantly tell you about the lumbar section? It's intact. If the lumbar section is intact, what do we know about the thoracic section? It's intact as well. Okay. I.e., if I damage something, we know everything below it. Like if I damage it right here, we know everything below it will be dysfunctional. That everything above it should be functional. Okay. So the reason why I say cervical and lumbar, this basically saves time. It's a shortcut.
I'm sorry. Why do you know the thoracic is fine?
The only way the thoracic could be fine is if the lumbar is fine. So take, for example, you got your patient, right? You poke them in the foot and they can feel it. That means everything upwards would still be good. However, if, again, it's spinal cord patient, you poke them in the foot, they're like, I can't feel that. Then you start tracking upward here until they can. So if you go to the lowest most point, then you know everything in between. BG. Okay. So cervical and lumbar, again, to save time. Because if the lumbar is intact, what do you know about the thoracic? It's intact as well. Okay. All right. So with the myotones, again, you do not need to know these in detail or specifically. Just saying certain myotones allow you to pronate, supinate, flex, extend. So if you are unable to do these things, let's say a patient gets into a knife fight and they can't extend their arm, well, then you know probably one of those nerves got cut. Okay. All right. So just talking about general organization here, nothing too crazy. The answers are on the next slide, so I'm just gonna skip that. Okay. Anybody remember sympathetic nervous system? What was the motto? Fight, flight, parasympathetic? Rest and digest. All right, so this slide right here is talking about autonomic nervous system, sympathetic division. These are layman terms, right? The following slide is the same exact information, just now we're going to use medical terms. So just saying this slide and this slide, they both start with fight or flight, same thing. Okay, we're going to be focusing on this slide because we're going to use medical jargon here. Elevated heart rate, what's the medical term for that? Tachycardia, yeah. Okay, again, talking about sympathetic fight or flight. Does tachycardia help us? Yeah, sends more blood to my muscles. Hey, take for example, running from a bear. Do you want your heart beating? Do you need blood to run? Absolutely. Okay, vasoconstriction of smooth muscle. So if I vasoconstrict, does that mean more or less blood? Smooth muscle, that's for digestion. Do I need to digest that granola bar right now? Okay, vasodilation to skeletal muscle, more blood to the muscle, fuels it. Decreased peristalsis, that means less digestion. Do we care about the granola bar? Not so much. Mydriasis. So be familiar with this one here. Mydriasis, this is pupil dilation. Why would my pupils want to dilate? Yeah, you can let more light in, you can see more, okay? Now, so the example I kind of use is back in grad school, I went to CU. kind of mentioned, the raccoons are huge. They are angry and they are hungry. And so it was about like maybe 11:30 at night. I was disposing some stuff in the dumpster. I throw a box into the bin and I hear this mad skittering going on. Me being the idiot that I am, I look into the bin. Two silver eyes are looking back at me. I'm about to get mugged. That's how that's going down. So I start backing away. My heart's racing because I'm trying to figure out, am I going to get into a fist fight with this raccoon? Or am I going to just GTFO? My heart's going, didn't really care about dinner. No peristalsis there. I could actually feel my pupils dilating. And then out from the side of the bins, I saw 4 more sets of silver eyes. I would like to say that I was brave. I stood my ground. No, I got the hell out of there. Okay. So, case in point there. There's also one more effect that's not listed here. What's another bodily effect when somebody gets so scared, for example? Defecation. Why would it be beneficial to defecate yourself while running from, I don't know, a family of raccoons? I didn't, but I'm just saying, use myself as an example. In poo, right? So exactly. So there's 2 biologists arguing about what's the point of like shitting yourself when you're scared. One of them's talking about it's to lose weight. You poop, you run faster. Yeah, biologists like legitimately at a conference. How heavy are your poops? Like how much weight are you losing? The whole idea there is just to be less appetizing. Okay. Now, because it's Halloween, jump scares all around. You guys have seen probably those prank videos. Somebody's hiding in the dumpster. They pop out like, and their friend, there's 3 reactions. One of them, like their friend freaks out, runs away. That's your flight. Person pops out. The second person punches them in the face. You guys have seen that? What's the 3rd reaction? They freeze. You don't need to write this down. This is me being a nerd. Why on earth would we freeze? I have no. Yeah. One of the ideas was, are you guys familiar with lemmings? They're like hamsters from New Zealand. Okay. They run in groups. As these lemmings are running across the field, and there's a hawk above, it caws and starts stinging to attack velocity. The lemmings are running and running and running. Some of them will freeze, kind of like a baby goat. They'll freeze and then fall over. Because they freeze and hit the brakes so quickly, the hawk zooms right past them and keeps chasing after the rest of the group. So for some reason, freezing seemed to help us with our survival. And that's why it's still around today. So that's why I say fight, flight, freeze. Fight or flight is usually what you guys are going to go with. Okay. All right, so on the other end, parasympathetic, again, that rest and digest. Here are your layman terms. We'll talk a little bit about medical terms here. Lowered heart rate, what's the term? Bradycardia. Okay. What's kind of interesting is there's no change in blood flow. Like we don't vasodilate or vasoconstrict here. Okay. Increased peristalsis means increased digestion. Which muscle is responsible for digestion? Say again? Sorry, I hear pains. What muscles? What kind of muscle is responsible for digestion? Smooth muscles. That means increased smooth muscle activity. Okay. But here we said rest and digest. What muscle is resting? Skeletal muscle. Okay, the way I kind of think of parasympathetic, this is when you go to an all-you-can-eat brunch and you kind of overdo it. Like you eat way too much food. What do you want to do after eating all that food? You want to sit, you want to chill, right? So That's parasympathetic there, rest and digest. Okay. All right. So this slide here kind of shows us the organization of the nervous system. This is going to sound a little wonky at first, but just kind of trust me on this. This is what you want to write in the margins there. Parasympathetic, let's say parasympathetic nervous system. Okay. The slogan, long pre, short post. Long pre, short post. The opposite is true for the sympathetic nervous system. Short pre, long post. And I promise to explain that. Let me ask you, what do you think your goal is? What is the goal of the parasympathetic nervous system? What is the goal of rest and digest? See? Part of it. Think about what are you trying to maintain for life? Yeah. So the goal is maintain homeostasis. Okay. That's the goal of the parasympathetic nervous system. Versus the sympathetic, your goal is to have an effect. You need something to happen here and now. Okay. This gets into the wiring, how things are wired in the body. So zooming in a little bit, a lot of it actually. Taking a look at the heart. This here is your pre-ganglionic neuron. That's your pre-ganglionic neuron. This is your, I should not have yours chose wrong. This is your post-ganglionic neuron. Long pre, short post. Okay. So let me kind of scroll down here to kind of give us a better visual. So sympathetic fight or flight, what this kind of looks like, you have a short short pre-ganglionic neuron next to a long post-ganglionic neuron. The space in between here, that's your ganglia. For your parasympathetic nervous system, you have a long pre and a short post. Okay. Why? So I'm going to go back up here so we can kind of see it here. When you're using your parasympathetic nervous system, is it every day that you go and crush Golden Corral? Hopefully not. Okay. Every day is a little bit different. You need to control each organ individually. For those days you eat a lot, do you want more or less blood to your stomach? More blood to the stomach, right? For the days you don't eat that much, you probably don't need that much blood. So what I'm getting at is this long pre-short post, by having this long wire coming out to each organ, this allows for individual organ control. Allows for individual organ control, which kind of makes sense. Some days you need one organ more than the other. Okay. Sympathetic, on the other hand, if I'm about to be mugged by a bunch of raccoons, do I have time to, increase my heart, dilate my pupils, good, direct blood flow to my muscles. Do I have time to do each action individually? I need to send one signal. So this is kind of what happens here. You send one signal and you notice it splits to the eyes and to your salivary glands. You send one signal, it splits to your heart and your lungs. What I'm getting at here is in the sympathetic nervous system, the Y, it is short, pre, long, post. This allows multiple organs to respond with one signal, or allow multiple organs to respond at once. Okay. So that's the Y between the short and versus the long. So sympathetic nervous system, short pre, long post. Notice your pre-ganglionic neurons, they release acetylcholine. That's acetylcholine. Okay. While your post-ganglionic neuron releases norepinephrine. Okay. So depending on if they're before the ganglia or after the ganglia, they release two different neurotransmitters. Okay. The pre-ganglionic neuron releases acetylcholine to activate the post-ganglionic neuron. Once I release norepinephrine onto my heart, what's that going to do to my heart? Norepinephrine, epinephrine, adrenaline. It's going to jack it up. That's the fight or flight response. Okay. Now, opposite for the parasympathetic nervous system, long pre, short post. So my pre-ganglionic neuron will release acetylcholine. The difference between the two, the post-ganglionic neuron in the parasympathetic also releases acetylcholine. Okay. So asking you guys some example questions here, pay attention to the wording. If a post-ganglionic neuron releases acetylcholine, which nervous system does it belong to? Parasympathetic. The post-ganglionic neuron, this one we're talking about, releasing acetylcholine, you know it's parasympathetic. If the post-ganglionic neuron releases norepinephrine, which nervous system does that belong to? Sympathetic. Okay. If I activate my sympathetic post-ganglionic neuron, what effect will that have on heart rate? It go increase. If I activate my parasympathetic post-ganglionic neuron, what effect will that have on heart rate? Should decrease it. So one more time, another question here. If I activate my parasympathetic neurons post-ganglionic neuron, what effect will that have on smooth muscle? So my post-ganglionic neuron is going to release acetylcholine onto smooth muscle. That's going to help me digest. It should increase activity. You guys see, just because parasympathetic is rest and digest doesn't mean everything just goes down. Heart rate goes down, sure, but digestion goes up. Okay. If I release acetylcholine from my pre-ganglionic neuron, which nervous system does that belong to? Sympathetic or parasympathetic? Yeah. If I release acetylcholine from my pre-ganglionic neuron, so this is my pre's, which nervous system does it belong to? Either one. I have to specify something else. I release acetylcholine from my pre-ganglionic neuron, and I see pupil constriction. Which nervous system does it belong to? Parasympathetic would be pupillary constriction. Sympathetic is the pupillary dilation. Okay, so just heads up, be careful with the wording, slow down, just make sure you kind of chew through it. Okay. All right, little side note here, epinephrine versus norepinephrine. For this class, there is no difference. You can use either one. I don't care. There's no difference there. Epi versus norepi, no difference. If you're curious, norepi is the precursor to epi. If you're curious. Acetylcholine, that's primarily for the parasympathetic. All right, so this is a much better drawn picture. So taking a look at the top here, your somatic motor neuron. Somatic means what? Yep, it's going to be voluntary. Okay, so if you want to have voluntary movements, signal goes through the ventral horn motor, and we release acetylcholine onto the muscle. Okay. What we were talking about was the autonomic. This is the parasympathetic and the sympathetic nervous system. At first, we have the preganglionic neuron. In the space of the ganglion, we will release acetylcholine, so that middle space. The end product is what varies. If I release acetylcholine at the postganglionic neuron, which nervous system is that? Release acetylcholine, parasympathetic, versus norepinephrine or epinephrine. That would be sympathetic. You guys see how they both, at the preganglionic neuron, both of them release acetylcholine? You only can tell the difference apart by the end product. Okay. All right. Somatic, voluntary, cool. Okay. This is going to be like the last topic, and then we'll give you guys a break. Nerve regeneration and nerve injury. So, regenerating nerves, easy or hard? Oh, extremely difficult. Extremely difficult. If you are lucky, you don't need to write this down. If you are lucky, you can get maybe a centimeter a year. Maybe. Okay. So, a couple of different things. The nerve needs to be myelinated for it to have a chance at regeneration. So, unmyelinated nerves, which we'll talk about in a little bit, those don't regenerate. Okay. The other thing is it has to be in the peripheral nervous system. Can you regenerate nerves in the central nervous system? No. Let me kind of explain why. So if somebody receives a spinal cord injury, you guys are familiar, that can lead to things like being paralyzed, yes? How long does it normally take for scar tissue to set in? Like how long does it take to make a scab on your skin? Couple weeks. It takes 15 minutes in your central nervous system. You form scar tissue that quickly. That means somebody hurts their spinal cord, paralysis is permanent within 15 minutes. Okay. And the problem is there a lot of space in your spinal cord or your brain, in your skull? Once we fill that space with scar tissue, you can't go back. So the reason why we can only regenerate in the peripheral nervous system is because that's where we actually have the space to do so. Okay. Fun fact, University of Michigan, I believe they just finalized patenting. They finalized the patents and they're in clinical trials. They're making an EpiPen for spinal cord injuries. What they do is it looks like an EpiPen. You inject it into the spinal column, and that basically causes immunosuppression in just the spinal column. So that means none of the immune system is activated, no scar tissue is formed. So imagine people rolling around, like I think of football, like NFL, somebody gets a spinal cord injury, somebody runs up, jabs them in the back, that gives 3 hours before scar tissue sets in. Also really beneficial for like ski patrol. If anybody goes skiing, somebody hits a tree too hard, Like this is gonna be some life-changing stuff. You guys are probably gonna be using this if you get into the emergency room. Okay. So myelinated PNS, and it depends on the injury, crush versus cut. So think about like your headphone cable. You guys remember when headphones used to have cables? Yeah, yeah. What's worse, to crush the cable or to cut the cable? Cut. Same thing with your nerves. Crush injuries are much more likely to heal than if they're cut completely. Okay. So let me kind of recap this here. Factors for nerve regeneration. Okay. Central or peripheral? Which one has a better likelihood? Peripheral nervous system. Myelinated or unmyelinated? Myelinated. Cut versus crush. Crush. Okay. And the last one is the distance. Actually, let me be honest with you guys. You don't need to write this fourth one down. You don't need to write this fourth one down. Distance from the soma. Excuse me. The closer we damage it to the cell body, the less likely it's going to actually regenerate. Is this something that you can actually look at as a nurse? Not really. So that's why I say don't even worry about that last one. But what you're seeing is we have an injury. The axon actually disintegrates. The myelin sheath turns back into these cells. What cells make myelin sheath in the peripheral nervous system? Make the blood-brain barrier. Close. Oligio central. Schwann. Very good. So here's your myelin sheath. Notice they turn back into Schwann cells. What kind of cellular change is that? Where one cell goes from being in one form, metaplasia. So we see metaplasia, they go back into Schwann cells. Notice I'm growing a new nerve. That nerve is growing blind. If it makes it to the target, awesome. Now my Schwann cells will go back, will undergo metaplasia, back into being myelin sheath. Not likely. I think this right here, this is the best case scenario. Okay. Regenerating nerves is very, very difficult. Cool. So let's take a little break. I don't know, a little bit like 10 minutes-ish, so 11:05. We're going to do a little bit of neuropatho. Still going to try to get you guys out a little bit early. A little bit of neuropatho, and then we'll call it a day. Okay.
Will the neuropatho be on the quiz tomorrow morning?
Neuropatho will not be on the quiz, just Neurophys. I'll announce that. That's actually kind of important to know. So I'll announce that when everyone gets back. Yeah.
I really thought. I'm gonna lose my shot. Is it like people back in? Like that's accessible. There's something that's fucking nice. I like that. I also like. Yeah. Yes. And like. My mind. Like that's better because my name. To read the sad thing is that it's one more. It's really that.
I just like a part of it. I was like, my brain is not.
Yeah.
It's like I just want to write on this. I mean, just never know. Right on it.
I think I did type it out. I'm sure it's unspent, really not that far. Maybe whenever.
Yeah, it's like, I don't know.
Yeah, and I just also bring.
I always love I swear to you, that's not something I often search. Like every time I try and look at the plus sign, then like, yeah, you can see it all. Look. I'm trying to do it just like that, so I'm like scrolling over this. I don't know. I'm not trusting with it. Not right.
Either this sense, so there's no way to call that.
They're picking out over the farm.
We were wondering what they were saying.
Yeah, I had them, so those kids are Q2 now. I had them last quarter. So you'll hear me commonly refer to you guys as my kids, because y'all are my kids. Yeah.
I have a question. So I had compartment syndrome.
You had compartment syndrome?
And I got surgery both either by or from all four of my compartments.
We will finally talk about that at the very last lecture of the quarter.
I love that.
I'm kidding.
I studied that so much detail.
Perfect. Yeah. So yeah, that'll definitely like literally. Unfortunately, I'm sorry, it does come up. But what's up?
So my nerve regeneration, I got the surgery back in 2016. And like it slowly has started coming back, but like it still have like no, essentially like my right foot, I really had songs on it. Like I don't have any superficial feelings with my legs. With that being, I also have my sciatic. So surgery.
That sounds like one hell of a malpractice
It
suit.
was really, I'll tell you another time, just a long story of what I went through during that, but, so what would that mean in terms of like what we just talked about?
So my guess is your myotones are growing back, which are awesome. So you're getting a little bit more control with that. One of the things I didn't mention, just because I also teach nutrition, vitamin E is actually really helpful for myelination. In terms of myotones versus dermatomes, didn't talk about it, but myotones have a greater likelihood of growing back than dermatomes, just because your skin gets filled with scar tissue. When and if the dermatomes do grow back, they grow back in a higher density. So if you do get feeling, you're gonna actually have hypersensitivity.
That's what's in my like feeling I do have my right big toe is like it's you can't even touch it. 'Cause it's so annoyingly weak on that fingersensitivity.
Because it's kind of like, remember I told you like that axon's growing, it doesn't know where it's growing.
Right.
So it's gonna keep branching and branching and branching. And then just like I'm thinking about like an apple tree, you have branches going everywhere. You need to trim down the branches that aren't producing. So over time, with the putting it into a shoe, walking around, stubbing your toe, that's gonna help train and push back those axons and say like, hey guys, tone it down.
So that's a good thing. So I'm like.
Exactly. It just sucks.
The first few years after the surgery was horrible. It's a lot better now, but like even wearing shoes, it was like the worst to wear any type of tight shoes against my toe.
Mhm.
Not going-
Oh, absolutely, absolutely. Yeah, I can get into it because I knocked out most of the nerves in my shin, but then it's because of martial arts. I needed to I didn't need to, but I killed the nerves in my shin so I could feel it. Stopped doing martial arts because great career path. Now like I can feel the gusts of wind. Like I never wear shorts. I don't wear shorts. Shorts are weird.
Shorts are weird.
Shorts are weird.
Even
would I wanna wear
someone
shorts?
is small, huh?
Yeah. Cargo pants, all right.
She only has just one leg.
I don't know, no. You gotta make a decision in life, all right? Life isn't about being wishy-washy. I don't do the zippable pants, you commit. You cargo pants, whether you cargo or not. All right, so talking a little bit about Neuropath, just to be 100% upfront, transparent, this is not on your quiz tomorrow. This is not on your quiz tomorrow. This is just to help jumpstart the conversation a little bit. So I don't need a lecture super fast tomorrow. Okay. So we talked about Neurophys, how things work. This is going to be the pattern for the rest of the quarter-ish. We're going to talk about the physiology, how things are supposed to work. Now we're going to talk about when things don't work, when things are broken. So this is the pathologies. Okay. So senses, you got 5 of them. Wow. I don't know what I'm supposed to say about that slide. I like asking this question because I actually don't know the answer to this. This picture here. Do you think it's staged or a legit accident? Like, do you think somebody paid this?
I think it's Photoshop.
You think it's photo? I think it's legit. I think this is legitimately an accident. The reason why I don't think it's staged, this kind of thing would require eye protection. Like OSHA would have a fit. I don't know, but yeah, snake face, not fun. All right, so talking about snakes in your face, pain. Let's see, the definition of pain is in red. I don't really test you on it, but it's more of like a Lindsay kind of thing. Let me tell you the takeaway point for me. Pain is ultimately subjective. Pain is ultimately subjective. Okay, it is unique, it can't be identified, it can't be measured, it can't be transferred. So what is worse? Kidney stones or childbirth? Pain is subjective. Some kidney stones, tiny. Some children, tiny. Other kidney stones, other kids, not so much. You see what I'm saying though? It depends on the person, their experiences, their history, XYZ. It is ultimately subjective. So as nurses, when somebody says, I'm in pain, kind of just have to take their word for it. Okay. Kind of keep that in mind because that is kind of a reoccurring theme here. Okay. So talking about how do we feel pain? We just did the exam. We're talking about prostaglandins. We talked about bradykinin. This is the tie-in here. Nociceptors are nerve endings that specifically detect pain. How they detect pain is they pick up on chemicals like bradykinin or prostaglandin. That's how your mast cells or your plasma protein systems elicit pain. There are two types of nociceptors. You have large A's that are myelinated, and small C's that are unmyelinated. So if you're looking at between the difference between a large A and a small C, which one would have a stronger signal? Large A's because they're myelinated. Okay. So kind of elaborating a little bit here. Large A's, they pick up sharp, well localized pain. Okay, what I mean by well localized is you instantly know which part of your body that you've dinged. Okay, the example I like to use is I want you to imagine you're at your place late night, you're thirsty, you gotta get a glass of water. It's like 2 a.m. Try and creep quietly through your house. You don't want to wake anybody up. You get a nice glass of water, refreshing. You start walking back, and then bam, you smack your pinky toe into the nightstand. How do you know that it's your pinky toe? Your large A's tell you. How do you know it's the right versus the left? It's your large A's. This is the alert. This is the alarm. Okay. Small C's come in. These are your reminder. This is your reminder kind of pain. It transmits dull, achy, burning, sore, throbbing, kind of poorly localized pain. Okay, so I want you to imagine, again, you just slammed your pinky toe into the nightstand. How's your toe feeling? Yeah, that's sharp pain, but what kind of pain follows after that? It's kind of dull, kind of throbby, kind of achy. And it's not just your pinky toe that is now pissed off, right? So the way I kind of think of it, again, your large A's, this is that alarm. While your small C's, these are your kind of, when you have an alarm, you have snooze, the snooze function. These are your reminders or your snooze function. Okay. Now those kind of work together. So this brings up the idea of gate control theory. The idea of gate control theory is basically you can use non-painful stimuli to close the gate on pain. Okay, the way I kind of translate it, this is using your large A's to override the small C's. You use your large A's to override your small C's. That's the way I kind of think about it. So just recapping what we just talked about, large A's, they transmit sharp pain and pain that is well localized. Your C's, they transmit dull, achy, throbbing, burning. It doesn't have to be all of these. These are different types of pain. sore, okay, kind of pain. Now, going back to this example, you just slammed your pinky toe into the nightstand. You have that sharp A's. Now the small C's are reminding you. What is your first reflex? What else? What do you do next?
Okay, grab
You want to grab your toe. Like, I'm surprised no one said purse. Like,
it. No, I see what's-
I turned French for a second there, but yeah, I start cursing up a storm, but then you want to grab it. Why would you want to grab it? When you grab your toe, does that feel better? It usually does, usually, not always, but usually. Why? Because when you grab your toe, you're applying pressure. Oh, nice. No, you're fine. You're applying pressure. When you apply pressure, you're activating your large A's. So what I'm getting at here is your nociceptors, your large A's, yes, they transmit pain, but they also transmit other signals like pressure. So if you have your small C's telling you like, hey, this is dull, this is achy, and now you apply pressure, which one's stronger, large A's or small C's? So which one will your brain pay attention to? The large A's. You notice how, again, we apply pressure here. We used a non-painful stimuli to override the annoying small C painful stimuli. Other things large A's can transmit: vibration and temperature. That includes hot or cold. Okay. So imagine you go work out at the gym. Your muscles are sore. What do you do for sore muscles? You rub them. Yeah, that's pressure. Absolutely. Yeah, I was like, dude, I'm old. I need the icy hot pack.
I love
Like,
like,
yeah, you apply that hot temperature. Your brain's paying attention to those large A's over your sore small C's. Okay. So what's another example? Does anybody play soccer? If you ever collided shins, okay, that sucks. What do you do after you collide shins? What do you do to your shin? I start rubbing the crap out of it. That's the vibration. Okay, so that's using, again, non-painful stimuli to override these painful stimuli. This can actually be used in your guys' practice. So kids and shots, great combination, yes? Like legit, up to 13 years old, it took 5 people to restrain me for a flu shot. Like I had a huge phobia of needles, hated it. Okay, I'm fine now, but like, ugh. What physicians or nurses will do is they have this vibrating pen. What they'll do is they'll put this vibrating pen on the kid's arm, so the kid's paying attention to this vibration. Then you come in and then you give the injection. By vibrating this area and giving an injection at the same time, you're messing with the large A's. What signal do you transmit, the vibration or the sharp pain? I don't know. Either way, less gets to the brain, less perception of pain. Why is this useful for you guys as future nurses? You don't have to fight small children, absolutely. Yes, this is ultimately the reason why this is important. This is pain management without medication. Okay, before we can give morphine to the gunshot victim, we need orders for that. Yeah. So what do? Keep pressure on the wound, keeps it from bleeding, helps keep that pain down. Okay, and then you can get your order, etc. So pain management without medication. That's the whole purpose here of the gate control theory. All right, so you guys remember how we talked about simple reflexes? This here is a complex reflex arc. You don't need to memorize it. The only difference here, hey, look, we're going to the brain now, which means now in a complex reflex arc, we are aware. Okay. So this brings up the pain pathway. This is just an overview, but these are the 4 steps here. I'll give you a hint or heads up in farm. This is what their test is on actually this week. You kind of need to know this. Sorry. Okay. So transduction, this is when we activate the nociceptors. Transmission. don't overthink this. Transmission is just we're transmitting it towards the brain. We're going from the peripheral nervous system to the central. Now, the perception of pain, i.e., now you are consciously aware. I'm just saying conscious of pain. And then modulation. What do you do about that pain? I.e., what do you do to try to control the pain? Control or lessen the pain. Maybe I'll put that in there. Control / lessen the pain. So that's the overview there. Okay. It doesn't get much more complicated than that, I promise. 4 steps. Cool. Transduction. Prostaglandins. Bradykinin. Okay, that's part of your innate there. The bradykinin, that was your plasma protein. Prostaglandins, that's your mast cells. Substance P. These 3 things, they activate your nociceptors. So remember how I told you guys don't learn and dump? Because I could very well have a question on the next exam about prostaglandins and bradykinins. Okay, see how that all ties together there? Okay. So whole point here, activate the nociceptors. Okay. Transmission, you don't need to worry about the structures, just peripheral nervous system to central. Good enough for me. Now we're talking about perception when you are consciously aware of being in pain. 2 factors. Pain tolerance. This is, you ever hear like how much pain can a person tolerate kind of thing? Pain is subjective. It's different for everybody. Okay. So generally speaking, this is the max amount of pain without disruption to ADLs. You guys heard about ADLs in health assessment?
Yeah.
So how much pain can you be in before your life needs to change? I have a Honda Civic. It's super low to the ground. I am not. I have back pain. Someday my back pain is going to get so bad, I'm going to need a different car. Okay. So that's the idea of pain tolerance. Pain threshold is the minimum stimulus to be recognized as pain. Minimum amount of stimulus to be recognized as pain. So the example I like to use is, imagine your foot on the ground and I put a 5-pound plate on your foot. I'm not dropping it. I'm saying I put 5 pounds on your foot. Is that going to hurt? Not really. Probably not. About 10 pounds. 15? 20? 25. You see, at a certain point, you're going to go from like to ow. That's your threshold. Okay. So in theory, if somebody has a high pain threshold, would they be more likely to perceive pain or less likely to perceive pain? Less likely. Okay. Last one here, modulation. What do we do to try to decrease the perception of pain? 2 ways for this to happen. Endogenous, endo. Anyone know what endo means? Versus exo? Endo means inside. Exo, therefore, is outside. So I want you to think, what is something inside of you that you can release naturally to decrease your pain? Endorphins. So that's why I'm saying, like, hey, take a look at that Latin. That can kind of help, yeah? Endogenous modulation. Endorphins are inside of you. You release endorphins, you feel less pain. Fun fact, endorphins are 7 to 10 times stronger than any opiate on the market. Your brain is really good at making heroin. It's kind of cool. Exogenous, therefore something on the outside. So tell me, what are things on the outside you can do to decrease your pain?
pressure. the
That's
weight,
gait control theory. What else can you do? Drugs. Yeah. Exactly. So exogenous is anything from the outside. So take, for example, taking aspirin to relieve your headache, ibuprofen for XYZ. That's exogenous. That's coming from the outside. Both of these decrease pain. Okay. So endogenous, the only thing you need to worry about this slide is the term endorphins. That's it. I'm not going to touch you about encalithins or dynorphins, just endorphins. Good. And that's where we're going to leave it. We're going to pick up on acute pain tomorrow. Okay. So I will try to have the exams released around 6:30, 7 o'clock. Do my stat stuff. See you tomorrow. We will be going, we'll do an exam debrief and then finish out this lecture.